My name is Will Pigeon. I'm the director at the Center of Excellence for Suicide Prevention in Canandaigua, New York. As we all know, suicide is quite a problem for veterans both in and outside the VA. My work specifically is focused on sleep research related to suicide and suicide prevention. My original thought was that people that have sleep disturbances are perhaps more at risk to develop suicidal thoughts and behaviors. The natural progression of that thought is to then ask, what happens if we improve sleep? Can we potentially decrease the risk of veterans who are on a trajectory towards suicide? So in this study that was HSRD funded, we examined 50 veterans and we delivered to half of them called cognitive behavioral therapy for insomnia, which I'll call CBTI. And we compared those folks to about 25 other folks who just received treatment as usual for either PTSD or depression. Now, all of these veterans were endorsing suicidal ideation, and they also had a diagnosis of either PTSD and/or major depression. In our study, the treatment as usual that was delivered was specifically for PTSD or depression. So many of the veterans were perhaps engaged in these other treatments, but they weren't getting a sleep intervention. They may have been getting a sleep medication, but typically that's it. And in this study, we found that indeed, as hoped for, this CBTI intervention not only improved insomnia a significant amount, but decreased the severity of depression and to some extent decreased PTSD symptoms. Importantly, there was a trend in that suicidal ideation also diminished in these veterans. That was not a statistically significant finding, but it looked to be in the right direction. So we're following up with a larger trial because this was pretty good evidence that in fact, improving sleep could indeed help folks who are thinking about suicide or on a pretty poor trajectory. So the study was also unique in that CBTI is typically delivered in individual face-to-face sessions over 6 to 8 visits. We wanted to address insomnia that occurs in primary care. And in a primary care setting, you don't have 6 to 8 one-hour slots to work with people. You have 20, 30 minutes and fewer sessions. We designed this CBTI intervention to be delivered in 2 30-minute face-to-face sessions and 2 20-minute phone sessions. And we found that it was as effective as CBTI that's delivered in the standard 6 to 8 session format. VA is a wonderful place to do research that can help veterans, not only because we're in the VA, but because there are so many partners that we can affiliate with who have different strengths. So important to us was a partner at the VA central office level, and that is the Office of Suicide Prevention, which has an overarching mission to prevent suicide, and there are a couple of centers across the country, including ours, that focus on that. In addition, we have a sister facility, a research center in Syracuse, New York, the Center for Integrated Healthcare, that focuses specifically on delivering behavioral interventions in primary care settings. And for our study, it was important that we reach the greatest number of veterans that we could, and those happen to be folks in primary care. Like many of us in the VA, I have relationships with veterans of multiple eras. To me, they always come to mind when we're conducting research with veterans, and particularly when I get to interact personally with veterans and hear what our research means to them, or perhaps even hear from them how our research could be better focused to address their needs. We're conducting work that we think is important, but that work can't be done unless we engage veterans in the research process. For this study in particular and other work that we do at the Center of Excellence for Suicide Prevention, I'd like to thank every single veteran who has volunteered to engage in research for the VA.